we had an awareness that prolonged door-to-balloon times were associated with worse outcomes. Then we instituted registries that said, you know what, we're going to track this. Then we instituted policies that said, you know, we're going to have public reporting and we're going to penalize you if you have longer door-to-balloon times. Is that a model for how we could do this in the cath lab? I mean, you can't leave the cath lab, for instance, until you make a diagnosis. We're going to track it. We're going to report it. But are there barriers to that? I mean, do you get paid? Can we get paid to do all the provocative testing for epicardial disease, to do the IMR for the microvascular disease, the thermal dilution, et cetera? So what do people think? Let's start with you, Roxana.
Well, I think we have to. We have to make a diagnosis. So I believe that today into 2022, no woman should come to a cath lab, have all of these diagnostic procedures, and get no answer. And I think that now we have tools.
Not only no answer, but they get assurance that nothing's wrong.
Right.
False assurance.
And I think now we have ample evidence that there is an association with worse outcomes in Manoka and Anoka. We also understand that half the time, sometimes there is just complete disregard to how to follow these women. And we actually have a whole story, and maybe Birgit will go into it a little bit, of the cardiac vasospasm group that these women who are living with vasospasm told us what it was like for them to live. And they gave their stories on our website. So, and most of them were told, well, there's nothing wrong with you, and they still don't have the perfect diagnosis. Maybe, Birgit, you want to go into that a little bit?
I think so. So we had this web conference with the International Heart Spasm Alliance, and it were several women on this web conference telling a very similar story about frustration and isolation and they actually brought up a good point. It starts with the ER in the emergency room, where they are told, oh, you are fine, it's not your heart, and then they get sent away. So they don't even enter any diagnostic pathway. So there is not even a chance that they would get any of those diagnostic tools that we have today. And so, but then even when they get somewhere to their cardiologist, they realize the cardiologist, they often got very defensive when they said, no, but I have pain, there is something wrong with me. And then the relationship between the physician and the patient got really complicated. And so these are all very personal stories, and it was, it was good that they shared it, and we want to put this on our website for everyone to know how it is to be in that situation, and that we need to do something about it. And then one of the patients said, only when I took the cardiologist's hand and said, look, we are a team, we are in this together, I'm not accusing you of anything, we are a team, we can do this, then it took the right path. And I thought that was a very good story and a very good experience to share for everyone to know.
But I think back in the old days of it's a plumbing model, your plumbing looks fine. The cath lab person says your plumbing looks fine. They didn't really have a way to respond, right? They said everything looked normal. But we have to move beyond that. So Dr. Merz, can we do it? What's the roadmap of how do we do it? Are there barriers there in terms of payment? What do we need to do to not let any woman leave the cath lab without a diagnosis?
Well, it turns out there are no barriers for payment, and you'll get paid more to do functional testing than you'll do to put in stents. And the codes are all there. And it's 3 to 4. It's like you get paid to put in the Doppler or the flow wire. You get paid to do an infusion. You get paid to do an injection. So it's ironic that we somehow can't do it. And you know, we had a period of time, I don't know if this is still true, but that, you know, the interventionalists were being chastised by admin if they put in more than 2 stents, because they were, you know, then you lose money because of the cost of the stent.
But they wouldn't be losing money were they to do
They
these
would not
tests.
be losing money for this. And so I really think it has to do with a perception that it's not valuable, and that, of course, stems from leadership and from teaching. It's not in the curriculum. It isn't.
But it needs to be, right? I mean, we
Yeah,
have to
it
change.
needs to be. Coronary vasospasm is an ICD-9 and 10 code, but why isn't it billed? And why are those patients not treated? So I think it is a leadership. The short answer is it's not a reimbursement problem. It is a leadership, education, awareness, and then I'm completely with you, needs to be guidelines.
So that brings us to our next panelist, Dr. Gulati, who's been a leader. You've been a chief of cardiology. You're president of the Society of Cardiac Prevention. You're a guideline member. Tell us the roadmap of how do we move from this very nice discussion to making change. That's you, Dr. Gulati. You're the leader.
Change, guideline.
Got it. Well, sorry, I'm not having trouble hearing because obviously I must read lips, and this is my challenge. I apologize. So I think that's why we put this in the guidelines specifically. I think for all of us who take care of women, we felt that this really hadn't been addressed, first of all, and so it wasn't in the guidelines, so everyone would say, well, there's really no basis of us doing this. Now that it's in the guidelines, I'm hoping that we see a change in response because it's clearly there. And, you know, is it a class 1 recommendation, all the things we outlined there? No, but it is based on trials that are, you know, with evidence of beneficial of outcomes. And right now that is really what we needed. And it isn't just women either. I mean, there is men with these issues as well. But since it's disproportionately women, I hope that it will change how we're practicing.
So let me ask you, Dr. Merz, if we were in the cath lab and we weren't quite sure what was going on, what is your algorithm of what would be the first kind of test you would do? Would it be provocative testing for spasm? Would it be coronary flow reserve? Would it be IMR? You know, how would you proceed?
Well, again, based on our prognostic data, and this has been replicated by Europeans and in Asia, Japan, and Korea, the failure to dilate is really the most prognostically important, and it is super easy to do. It's a squirt of adenosine, either systemic, intravenous, as you would do for an FFR, or intracoronary for a CFR. But it doesn't matter. We published, one of my fellows published a paper that you just adjust for the heart rate change if you're going to do peripheral. And that is done in every well, it's not done enough, obviously, FFRs. But
It can be done. It can be done.
But the capacity to do it is there and easy. And so, you know, one of the things to do as well, and the Lancet and Dr. Mehran and our colleagues here did it very well, partnered with industry. And we should be partnering with industry, and it'll help them sell IMR catheters, and it'll help more patients get diagnosed. So,
Yeah, the thing I find a little frustrating about CFR, coronary flow reserve, is it can vary a bit depending upon where you're interrogating the velocity. So high up in the vessel, you could have pretty good health of the microvasculature, but lower down in a region, it could be unhealthy. So I always call it a little bit of the mystery wrapped in enigma that's a riddle wrapped in secret sauce. I mean, it sounds easy, but it can be a little more challenging.
But if they truly have no obstructive CAD, then you're gonna, and your LAD is your easiest, in and out, boom, boom. You don't have the RCA spasm problems. It's pretty homogeneous. I probably misled you by showing you that, the bridge example. But I show it because then seeing is believing, right? And if you're dealing with interventional cardiologists, they're so anatomous these days. So if they don't see it, they don't believe it. But most of these patients do not have near obstructive CAD. Bridges are not common. And we demonstrated that early on. We did PET scanning, which is, you know, the PET will be homogeneous coronary flow reserve, myocardial blood flow throughout the whole heart. And the LID's pretty good most of the time, good enough for government work.
So there's one thing I was hoping you would say, the LED is good enough. So, no, it's important, because what about the LED? The LED kind of comes out in the front of the chest, and, I've talked in the past with Carolyn Lamb, who's done some work using echo to interrogate the LED.
Yeah.
You wouldn't want to bring someone back to the cath lab over and over and over again. I mean, are there some ways using echo or maybe PET or something to make serial assessments to guide therapy? Do we always have to go to cath lab, or do we have other ways?
Well, so the Italians have done a lot of Doppler LID, and the last time I was in Italy, they're a lot leaner than the U.S. We tried, but we failed to consistently be able to visualize that. So we pretty much rely on, in my center, because we're so good at MR, we have excellent experts, but not everybody has that. We use a lot of MR for global flow, but PET works well. And again, sometimes you have authorization hurdles, but persistent chest pain, large breasts, and obesity are all good, often will help you get that authorized.
It'd be great if we could have a less invasive way. I just want to bring to everyone's attention, there is a paper, a trial being presented here at ACC, a randomized trial looking at diltiazem for treatment of coronary vasospasm and microvascular dysfunction. So stay tuned for that. Also stay tuned for the messaging about whether these two are linked. Is epicardial vasospasm related to microvascular spasm, or are they different? What do you think?
Well, I think one of the things that we know about physiology is there's a tremendous amount of contributors, or maybe put a different example. What about dyslipidemia? Is it just one problem? No, it's a lot of problems, and we know how to phenotype people. But it's a simple solution, lower LDL. At least those are the tools that we have right now. So to make that analogy, testing flow reserve in otherwise, non-obstructive coronary arteries prognostically is very useful. And we're testing whether or not treating it will reduce events, similar to, we now know statins work, and it's widespread, and a lot of people have benefited from it. So we'll see.
Now that we solved the diagnosis problem, and hopefully you'll put together some position paper after this as a call to action. But let's talk about the call to action on the treatment side. We hadn't heard from you yet, Dr. Spatz. What do we do? What do we do to narrow this gap? We're aware of the gap. What do we now need to do to narrow that gap in treatment?
Well, I think as Dr. Bairey Merz has noted, we need to utilize what we know works, firstly. So we need to make big strides in getting cardiovascular risk factors under good control. And hypertension, uncontrolled blood pressure, is a significant contributor, along with obesity, to microvascular dysfunction. So I think that there's a lot to be gained in getting people to guideline-directed BP goals and weight, along with physical activity, because those things can prevent and treat the disease. The second stage is when you do have somebody who has ischemia that you've diagnosed on a stress test, for example, is going the additional mile to diagnose microvascular dysfunction or vasospasm, because that does lead to more targeted treatments, and many people don't want to be going through cycles of empiric therapy and still suffering, and want to believe that people need a diagnosis and then they're willing to take the therapy. But if they feel like their diagnosis is in question, there's a big challenge to get people on the multitude of medications that may be needed to treat their disease. So,
Other suggestions? I mean, Dr. Vogel, in where you come from, I'm sure you face the same problems in your native country. Maybe not as bad as here, but what would you suggest?
Yeah, I mean, just one word to the treatment, maybe also from what on the web conference was what women were telling me. Actually, each of them were really on different treatments, and almost, I think none of them was on the treatment as the first. It was already like the second, third, or even more choice. So they had to try different medications, different treatments, and only at some point they got to something that was helpful for them. So I think this is a very multifactorial disease, and it might be that different strategies work for different people. So in case of the country where I come from, yes, I mean, medicine is socialized, and it's not about what is reimbursed and what not, but it's really, the capacity is often not there because the schedule is, it's just often long waiting times for procedures, and also not all centers often offer all the possibilities. So patients maybe have to go further away to get treatment or diagnosis, and that can be a challenge. But I think that might also be a challenge sometimes in this country as well.
Yeah, the heterogeneity in treatment is striking.
Yeah, I mean, I think what this is telling us that we have a lot of work to do. We know the problem. We think we know how to diagnose it. Noel is doing a beautiful randomized study but I just don't know, how do you design a study? How do you implement treatment when you actually don't really know which way to go?
That's why the diagnosis was the first step.
Yeah.
The other thing I wanted to hit on was, it was a great presentation, Martha, on pregnancy. But what I didn't see you mention was microchimerism. When you are pregnant, some of the fetal cells will cross the placenta into the maternal circulation, and you do develop some clonal-hematopoiesis, and we now know that clonal-hematopoiesis can be involved in CAD. We certainly know that women have a higher rate of autoimmune disease, and we are learning more and more that a lot of this is mediated through clonal hematopoiesis. If you look at the lung in lupus, you can actually see male chromosomes there. So, do we know enough about this? As a chronic disease risk factor after that? Talk to us a little bit about that.
If I understood correctly, you said that beyond the pregnancy issues, I'm sorry.
Beyond pregnancy kind of risk factors that you went through, another one might be clonal hematopoiesis, this microchimerism. Yeah, there's microchimerism where the fetal cells take up residency in the mother and causes autoimmune disease.
I think that's an important point, is that, and even Sadia Khan will be, I don't know if her talk will address this too, but I do think that there's, the offspring issue is another issue to be discussed as well, and that somehow is being pronounced during pregnancy. So it's another generation that we are also talking about at the same time if we're ignoring a woman's health at the time of pregnancy. And so, we didn't dive into all of this, but even the maternal mortality rates are on the rise. And most of the causes of death are due to cardiovascular disease as well.
And finally, how much of it of risk is mediated by the recognized risk factors that we're all familiar with, and how much of it is mediated by the unrecognized risk factors that you showed? Give us an estimate.
So there is data showing that there's women who have, none of the traditional risk factors, none of the known risk factor, the sex-specific risk factors, who are still developing cardiovascular disease. So I think there's a lot we still don't know, and I think that's the question, I think, for all of us here to answer, is what else do we not know? I think we're at the earliest stages of really studying women. It's been only a few decades that we're actually looking at them, looking at things that are sex-specific. For me, the biggest example of something that shocked me that we didn't look at sooner, for example, was like troponin levels. And why wouldn't they be different for women versus men? And then with the high sensitivity troponins, that's what evolved. But it took us a long time to get there to even think that there would be some biological difference. So that's just an example, not of a risk factor, but of something that we use every day that we never question. Because if we only study men, we're not going to even think about what's normal for women.
I want to see if we have any questions from the audience. Don't be shy. Oh, great. Excellent.
First, thank you for this great discussion. There's a lot of activity screening for different diseases like breast cancer, colonoscopies, but the carriers don't want to pay for screening for cardiac diseases. And of course, as you see, the cardiac disease is the biggest killer. I have a hard enough time getting a test in symptomatic patients, let alone asymptomatic patients. So how do we address this?
Well, there's a real drumbeat to try and address these issues in underdiagnosis.
I arranged that.
Roxana, how do we address this?
Well, really good question. And I wonder how Martha and Noel, Martha, especially you, in the chest pain guidelines, I know that you led the guidelines. So what was your approach to that? Because we're all having this trouble trying to get screening. I mean, getting even a calcium score to best stratify a woman is near impossible. So what was your approach in the chest pain guidelines?
So a lot of people might not appreciate, but within the chest pain guidelines, we also addressed prevention actually within there. And we did make a push that sometimes you will have somebody who presents with chest pain even when it's non-cardiac. We're doing a lot of testing on people who are lower risk. That's what, if you look over time, like we used to cath more people that were higher risk patients, and now that it's more available, we're seeing more patients, we're doing more testing. But one of our recommendations in there that is probably hidden, but is that when you have a patient using coronary artery calcium is actually incredibly useful because one, the patient wants an answer. They want to know what's going on, especially when they present with chest pain, which is different than screening. But when they have symptoms, they want to know, and there is some reassurance to know that there is no blockage, that maybe there's something else going on, but at least knowing that can help them. And using that information, we don't just stop there, okay, there's no blockage, but to use that information to help guide preventative care really should be the next step. Knowing that even if you have a little bit of plaque or something, you still need to is all these risk factors being addressed. From the question from the audience, though, about making it, affordable from screening, I think, with the Affordable Care Act, we're all hoping that all the parts of prevention would be covered. And I think we need to be continuing to push that we are able to screen our patients and work with primary care people to also make sure that that is the first thing that gets done. Why the number one killer is not being something that people are measuring or something that people are actually doing. It's nice they're getting their mammograms. They need their mammograms, but they also need cardiac screening.
Excellent. Yes, another question.
First of all, congratulations. This has been a phenomenal session. So you talked about raising awareness and the proposal that the analogy to DCB where then they created a registry. We're at the ACC. Is there a potential to tap into that chest pain a registry or through the NCDR in order to get data where we can either prospectively start collecting these variables or even retrospectively going back and looking? If 50% of the patients that leave a cath lab leave with the diagnosis of non-obstructive coronary disease, how many of those are you missing because you're not making that diagnosis? And so is there a capacity to tap into that and start collecting that data?
We are so lucky to have a member of the ACC Board of Trustees with us today, Dr. Roxana Mehran.
Well, it's an excellent question and a way forward, right, for us to think futuristically about this, because we can no longer sit back and say, you have a lot of non-obstructive disease because you're doing unnecessary caths. if most of those and I remember this was a JAMA article that placed a lot of unnecessary caps perhaps for, and it could have been that most of these were women with non-obstructive disease. We don't know those details. So we're really kind of got to get our arms around what's really going on. How do we have an algorithm that makes sense for women? How do we design trials and understand better how to diagnose and treat women with non-obstructive disease and ischemia or myocardial infarction? All of these are very, very important next steps for the future. And I think as we raise awareness, that's part of the action items. Collecting the real-world registry data, and then hopefully designing trials. That's why Mike Gibson and Bob Harrington are here for the future. Because we can't just keep saying we don't have answers. Now we'll make a diagnosis and we don't know what to give them. Why should I make a diagnosis if nothing works? These are the questions that clinicians want answers to, and patients want answers to. When we identified the vasospasm ladies who spoke to us, and all 4 of them had 4 different regimens for the same diagnosis, and none were feeling great with the quality of their life, it makes you think twice that we absolutely have to do something more than what we're doing now. So there's a lot to be said here and to unravel.
Thank you. Let's get one more last question. Yes.
Hi there, my name is Odaime Quesada. I also wanted to raise one important issue that we're running into, because we do have functional angiography for INOCA patients in our hospital, is actually getting the insurances to cover those, because we constantly get those denied, and then we have to spend hours on the phone explaining why this is important, even though the patient had a normal angiogram when we're trying to order a CRT.
I mean, to me, it sounds like we need a paper, Noel, for advocacy, because we just heard two people tell us that insurance companies aren't paying for screening, and they're not paying for diagnosis for women.
Yeah.
How do you respond to that?
Well, 2 thoughts. When Martha was responding, I remembered the breast cancer lobby. As a neighbor, Susan Love is a neighbor, and I remember in the 70s and 80s, she was leading a female community charge that was advocating government to regulate insurance companies. They were also trying to get so women wouldn't be kicked out of the hospital within 24 hours of birth. Remember that? But this was very strong grassroots advocacy, talking to legislators and saying this is not okay. So I think we could harness that vasospasm group, as well as INOCA International is quite active. And then number 2, I think the suggestion, and I think this is a fabulous suggestion, because what does NCDR do? It's a quality mark. The college established it because of, they saw the future was we're going to be paid for quality. And it's also a regulatory mark. If you're going to get paid for it, remember the stenting and the ICD stuff, the college has very well assisted with that. So I think this is a great suggestion to go to NCDR and talk about a chest registry, a quality of, and they could partner it with the PCI, right? Because we're still having a fair amount of probably inappropriate PCI. Yeah.
Well,
And
NCDR
give them
stands.
something to do.
And
But in
NCDR.
that data, they'd already have, we already are collecting most of the data. The thing that we need the registry to do is add some points. As a diagnosis being made, are they doing CFR? What was the end? We know they have been reporting the non-obstructive coronary disease, but we need more than that.
I think NCDR now needs to stand for now cardiac diagnosis required, to leave cath labs. So I think we've got to move in that direction. I'm also very excited. There's a lot of advances being made in CT technology. Now we can do CT FFR, but I've actually been reading and reviewing some work on CT IMR, which is another way where we wouldn't have to do all this fancy instrumentation. So great session, a lot of underdiagnosis, a lot of undertreatment. First step is to demand a diagnosis. We can't treat if we don't have a diagnosis.